Today we're going to talk about Chapter 5 in your Applied Pharmacology book, which are drugs that affect the respiratory system. If you understood the nervous system and the way that nervous system drugs act, then this is going to help you tremendously through the rest of this course, because a lot of these drugs that we use are affecting that nervous system because the autonomic nervous system affects most of the body. So until we get to anti-inflammatories and anti-infective drugs, we're going to be talking a lot about these nervous system drugs that affect the autonomic portion of the body, so either sympathetic or parasympathetic. We do need to talk a little bit about the respiratory system, remembering the anatomy of it, the nasal cavity, the pharynx, the larynx, including those muscles that are there, the trachea, the bronchi as they split off and go into the lungs, the diaphragm and intercostal muscles, which are required to expand and contract the chest so we can have ventilation, and the respiratory center, which is in the medulla or the brainstem, and that is where a lot of this, the movement and the ventilation and the diffusion, the perfusion, everything that's supposed to happen with the respiratory system, that's where it's all coordinated. The chief functions of the respiratory system are to supply oxygen to tissues and remove carbon dioxide from the tissues. Also, as you bring air in, we want to warm that inspired air before it gets into the body. Also aid in evaporation of air from the respiratory passages. So this evaporation helps to regulate the core body temperature. The nasal cavity contains bones that are covered with mucous membranes, and these nasal conchae increase the surface area of that nasal cavity to allow humidification and warming of that inspired air, but also to aid in the evaporation of expired air as well. Other functions of the respiratory system, these are secondary functions. Regulation of the acid-base balance by removal of carbon dioxide from the system, and also voice production. Remember, air is passing through those vocal cords. That's how the noise is produced from the animal. The work of the respiratory system can be divided into 4 parts: ventilation, distribution, diffusion, and perfusion. So what is it? Ventilation. Breathing in, breathing out, movement of air into and out of the lungs, diffusion of oxygen from the alveoli to the blood, and carbon dioxide from the blood to the alveoli. So as blood comes in, carbon dioxide starts to diffuse out into the alveoli, and oxygen starts to diffuse in, and now we have oxygenated blood going out. This oxygenated blood is transported or distributed to the body cells, and carbon dioxide is taken out of the body cells. And when it goes to the body cells, that is perfusion of oxygen into the body cells. How is it regulated? The center, the regulation center, the respiratory center, receives information from receptors in the blood vessels. There are higher centers of the brain that coordinates the response to that, and that is coordinated through the autonomic nervous system. The autonomic system plays an important role in controlling and adapting respiration to the body's needs and demands. Inspiratory and expiratory control, so whether we inspire or expire, is usually passive, and the rate and depth of respiration, how deep and how fast we respirate, are controlled by the autonomic nervous system and the respiratory center. So why do we cough? Why do we sneeze? With coughing, there is afferent or sensory stimulus from respiratory sites, so it could be your pharynx, your larynx, your trachea, or within, not as much within your lungs, but if you do have debris in your lungs, that can stimulate a cough reflex. And it's through the vagus nerve, the cranial nerve 10, to the brainstem that this cough reflex happens. So if we think of spinal reflex, we have a nerve that goes to the limb and then comes back to the spinal cord. This is the same thing. This is the vagus nerve, which is a cranial nerve that goes to the lungs, or along the larynx and pharynx and trachea and down into the lungs, and then feeds back to the brainstem, the first part of the spinal cord. This causes contraction of the muscles, sensory receptors from the pharynx all the way down through the lungs, and constriction of the bronchioles. When we constrict the bronchioles, we make it easier for debris to come out. So you get a much stronger exhale with constriction of those bronchioles. This is what happens when we have sympathetic stimulation. We have a dilated bronchiole. When we have parasympathetic stimulation, we have a constricted bronchiole. With the sneeze reflex, we have sensory stimulus from the nares, from inside your nose, through the fifth cranial nerve to the medulla. So if the cough reflex is cranial nerve 10, sneeze reflex is cranial nerve 5. Carbon dioxide has a direct excitatory effect on the respiratory center. Carbon dioxide, you probably didn't know carbon dioxide was so excitatory or so exciting. But if we have too much carbon dioxide in our body, then our medulla will be stimulated to make the body breathe. Okay, an excess of carbon dioxide will greatly increase the strength of both inspiration and expiration signals to the muscles, and we'll see both an increase in ventilation. An increase of ventilation increases elimination of carbon dioxide. So if we see increased carbon dioxide and we increase ventilation, we'll decrease carbon dioxide in the system. So what does that sound like? Increased ventilation is hyperventilation. That'll be hyperventilation. Breathing out rapidly will get more carbon dioxide out of your system. Just stimulated my cough reflex through my larynx. So oxygen does not have a significant direct effect on the respiratory center. Oxygen acts on the peripheral chemoreceptors located in the carotid and aortic bodies. And so I'm trying to get my pen here. The carotid bodies and the aortic bodies are located in these vessels. And when oxygen levels are received here, that information does not go to the respiratory center. It actually goes to the kidney. Okay, here's my little kidney. If the kidney has gets information that there are decreased levels of oxygen, what it's going to do is send erythropoietin, bones. And in the bones, in the bone marrow, we're going to make red blood cells. Red blood cells carry oxygen. So the more red blood cells we have, the more ability we have to carry any oxygen that might be available in the body. Okay, so oxygen does not affect the center. All right, here we are on our drugs. We have several categories of drugs. We're going to talk about respiratory stimulants. How do we get an animal that's not breathing to breathe? We're going to talk about cough suppressants. We're going to talk about when we have mucolytics and expectorants to try to make the cough more productive. We're going to talk about how to reduce the stimulation of the cough by reducing histamine in the system, and also going to talk about corticosteroids work, etc. So we're going to have a couple of different categories, and I want you to remember these categories. So respiratory stimulants, we start with doxapram or Dopram. We do not want to give this drug. We've seen this in our CNS portion, in our nervous system lecture. So this is a nervous system drug that works on the CNS. It will not work if we have something physically stopping the lungs from expanding. So pneumothorax, where we have air in the thorax, or hemothorax, where we have blood in the thorax that keeps the lungs from expanding. It's not going to work. It's a liquid or IV medication. It causes CNS depression. So even though it is a CNS stimulant, it only works primarily in that medulla, so the rest of the CNS will be depressed, but it stimulates the medulla. Okay. The other two work because they stimulate the CNS and antagonize CNS depressants. So these are reversal agents or antidotes. This is naltrexone or naloxone, or similar to Narcan. So it is a stimulant because it takes away opioids or narcotics. Yohimbine is a antidote to xylazine. So it takes that away. So that's how it stimulates it. Antitussives. This is indicated for the treatment for non-productive coughs only. If you have mucus or debris in your lungs, you must get that out in order to live. So we want to block the cough reflex only if we have nothing in our lungs that we need to get out. They can work either peripherally on the larynx, um, uh, pharynx, trachea, bronchioles, or the lung, or they can work in the medulla on the cough center centrally. Butorphanol tartrate and dextromorphone both work centrally in the medulla. Both of these have orph in the name, orph. That means there's some relationship to opioids or morphine, right? This one is an opioid partial agonist, antagonist, and a controlled substance. We've learned about this before. It has direct suppression of the cough center in the medulla, and it's approved for a relief of non-productive cough, but it can cause the animal to be tired or sedate. Dextromethorphan or Robitussin is not controlled because it's not addictive. It is also not analgesic. It does have some of the same properties as butorphanol, but it's less effective. So it does act centrally on the cough center, increases the threshold for cough, which means we have to increase the stimulus to cause a cough. But we can see some drowsiness or minimal constipation, as we might see with butorphanol tartrate. It's not as bad. Temerol P is a combination drug. It's a combination product that has trimeprazine tartrate and prednisolone in it. So this is a centrally active antitussive, and this works because of anti-inflammation, and also antihistamine release. Okay, it's antitussive, and we use it as an antipyretic in animals that are itchy. Adverse side effects would be sedation, depression, hypotension, and minor central nervous system signs. Mucolytics and expectorants. If we have an animal that is producing stuff when they cough, so they cough something up and they may swallow it down, or you'll see it on the floor, we want to use these drugs to reduce the thickness of the secretion so that they can come up more easily. We have a normal mucociliary apparatus in our respiratory tract that allows things, grabs hold of things, and brings it out of our system when we cough or when we sneeze. We need that to be working, and in order for that to work, we need to make sure that we can get things out. Mucolytics and expectorants are different. Mucolytics break up or lyse the mucus to reduce its viscosity, so it makes it less thick. Then the cilia can move into the affected area to fight the infection or help prevent cellular damage. So if the mucus is too thick, the cilia cannot move. If it is less thick, then the cilia can move and do its work. Expectorants add water. So expect water. Okay? They increase the fluidity of the mucus in the respiratory tract to improve the effectiveness of the mucociliary apparatus, which allows us to cough things up. If we're going to expect water to be added into the mucus, we need to increase water in the environment by increasing humidity, or in the patient by increasing their hydration. So here's the difference between mucolytics and expectorant. I've given you an example of each. A mucolytic, also known as mucomist, it breaks down to make it less thick. It does have a short shelf life. We have to use within 4 days. It's a little bit expensive. It does also treat acetaminophen toxicity. So what is acetaminophen? Tylenol. So if you have an animal that gets into Tylenol or takes too much Tylenol, we can give acetylcysteine. It's most commonly used as a nebulizer. That means they're breathing it in. It can also be used as a topical for KCS treatment. KCS treatment is dry eye. Remember, with dry eye, they actually have a kind of mucousy appearance to their tears because it dries up the watery tears, but it maintains the mucousy tears. And if we can break up that mucus and make it a little bit more watery, then that can act as um, a watery tear. On the other hand, we have the expectorants. An example would be guafenicin or Mucinex. Guafenicin is in Mucinex. Remember this little guy here in the commercials, the Mucinex guy. We'll just call him guafenicin. It stimulates more watery secretions from the respiratory cells. This will increase thirst, so it adds water. We also use it in horses to aid in intubation, it causes relaxation of the respiratory tract, so the larynx and the pharynx, and it can cause drowsiness and weakness, and that increased thirst. Next, we're going to talk about bronchodilators. This is another category. What causes bronchodilation? Normally, the sympathetic nervous system. Parasympathetic nervous system is going to cause constricted bronchiole. So what are we treating when we have bronchoconstriction, bronchospasms, or obstruction? Dyspnea can be caused by a number of different things. Asthma, primarily in cats, and heaves or recurrent obstructive airway disease syndrome. And that is found in horses. Okay. Cats for asthma typically. Horses get heaves. It's like COPD. Looks a lot like asthma, but it's slightly different. Causes of constriction of the bronchiole. We can see contraction of the smooth muscle surrounding the small bronchioles deep in the respiratory tree, and that's what we see with asthma. We can see stimulation of the parasympathetic nervous system, which increases secretions and causes bronchoconstriction, and that causes dyspnea. And histamine release from mast cells causes allergic bronchitis. Bronchoconstriction results from acetylcholine release at the parasympathetic nervous systems or stimulation of H1 histamine receptors and beta-2 blockade of beta-2 adrenergic receptors. So here's an example of the parasympathetic nerve on smooth muscle cells causing contraction. Excuse me, the histamine receptor is also on those smooth muscle cells, and here's the beta-2 adrenergic receptor. So what's the best way to bronchodilate? Well, to mimic the sympathetic nervous system. Specifically, we're going to target that beta-2 activity. We know that beta-1 has to do with stimulating the heart. Beta-2 is going to cause that respiratory tree to dilate. Good asthma meds would be terbutaline, albuterol, and metoprolol. These are selective beta-2s. They're good for bronchodilation or asthma, and we use them for asthma. Isoproterenol is an emergency medication. It has both beta-1 and beta-2 properties. And epinephrine has all receptor activity, alpha, beta. So it's used for last true crisis. Methylxanthines are also bronchodilators. They have some mild stimulation of the heart and respiratory muscles and some minor diuresis, which means it's taking fluid away from the respiratory system, away from the body. Both theophylline and aminophylline I keep in the same box in my mind. They both cause bronchodilation. And aminophylline is essentially theophylline with added salts. The added salts allow it to be absorbed better and decrease GI issues because it's taken out of the GI tract sooner. So if they're stimulating the sympathetic nervous system, they're going to decrease the GI system. So if we can remove those effects by getting them out of the GI tract sooner, that can be helpful. Both of them inhibit an enzyme in the smooth muscle cells to cause bronchodilation. Caffeine and theobromine are both found in chocolate, and they do the same thing. Antihistamines. So we're going to talk about antihistamines. This is like diphenhydramine, Benadryl. This is chlorotrimeton. These are both over-the-counter drugs. Hydroxyzine, hydrochloride, is also known as hydralazine, and that is a prescription. Definitely worth it. For dogs, I think, okay, especially for skin issues. Antihistamines are competitive antagonists, so they block the binding of the histamine at the receptors, but they do not fully stop the release of histamines. Remember, steroids are going to stabilize mast cells and block the release of histamines from the mast cells. Antihistamine should be used as preventive measures, so we want to use it before we think we're going to need the bronchodilation. They have a mild central action also, suppressing the cough center. They help reduce histamine-induced bronchospasms. They can also inhibit the vomiting center as well, and we will talk about the use of antihistamines in GI as well. Their adverse effects, they can cause sedation, GI upset, and dry mouth. Decongestants reduce the congestion of nasal membranes by reducing associated swelling. Increased hypertension due to vasoconstriction of the blood vessels. They are administered as a spray or as nose drops, or may be given orally as a liquid or a tablet. Some examples would be neosynephrine, phenylephrine, pseudoephedrine, and ephedrine. And again, what they're doing is if we have congestion in the nasal membranes, it's because we have a lot of blood flow there, and they're bringing a lot of fluid and inflammatory cells. And so if we constrict those blood vessels, we'll reduce the congestion. Corticosteroids are used to decrease the inflammatory response, but we have to be very careful, because if we decrease the inflammatory response, we will make an infection worse. So if there's an infectious agent, we don't necessarily want to use it. They're also used to stabilize mast cells. So they're going to stop the mast cells from releasing histamine. We use this in the treatment of equine heaves, which is also called ROAD, at feline asthma, acute respiratory distress syndrome, and allergic pneumonia. Allergic pneumonia, not infectious pneumonia. There are a lot of side effects for corticosteroids, including PUPD, some liver side effects, some anxiety, restlessness, some polyphagia. So a lot of side effects with corticosteroids we have to be careful with. That's it for respiratory drugs. Again, they all kind of relate back to things that you already learned from the nervous system. So just go back and use your flashcards, put the stuff in StudyMate Campus, and start to build your list of drugs that you understand and know.